So if we talk just a little bit about lower urinary tract symptoms, because that's the other big referral group that we get, not as much as it was because of the new NICE guidelines. But as you know, we divide the symptoms up into these two groups, voiding and storage symptoms. I'm not sure that that's particularly helpful, voiding and storage symptoms, but we do. What are the sort of red flags looking after somebody in primary care that makes you worry about a patient? Because these days you're going to treat most of these people, aren't you, in primary care first of all. So a man who's got lower urinary tract symptoms, maybe he's 60, he's come along, he's getting up twice at night. What symptoms make you nervous about him?
Weight loss.
Yeah?
Back pain.
Yeah?
Blood in the urine.
Blood in the urine, yeah, okay.
Abnormally being felt prostate. Abnormal DR.
Yeah, okay, so yes, that's a clinical finding, yeah. The one I find comes up every now and then, patients that come along and they say, it's a funny thing, but I've not wet the bed in years, and I've just started wetting the bed. What's that? It's always overflowing continence. Now the trouble is that if you examine them, you think, oh, I've got fantastic Victorian clinical skills, you know, I can spot a bladder. But actually, they've quite often got floppy bladders. So you can examine their abdomen. These days, you know, everyone's got a BMI of 30 at least, so it makes it harder. And if they've got a floppy bladder, you're never going to feel it. So if somebody says, I've just started wetting the bed on occasion at night, they've got chronic retention. The other things that we worry about are men who've got recurrent UTIs and urinary symptoms. That's probably going to mean that they've got something underlying it. And then the other things you pointed out. So there is a way. Oh, yeah, go on.
Sorry, when I qualified,
yeah.
a man had to be referred with even one UTI. He wasn't supposed to have a UTI.
Yeah.
Is that still the case? Or?
You're cheating. That's in my talk in a bit. But it's a good question. In terms of working out who's bad, you know, the difficulty with men is that we're pretty unreliable witnesses, aren't we? I think half the audience would agree to that. So if you ask a chap about his urinary symptoms, it's difficult to get a story. So have you all heard of IPSS sheets, International Prostate Symptom Score sheets? So I think it's worth getting a patient to fill out an IPSS sheet. It's quite a good way to say to the chap, go away and think about what your problems are like, come back and see me, fill out this chart. The other thing you can think about is a frequency volume voiding chart. Have you heard of one of those? Yeah, so it's a simple chart. It's just Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. And then they need to write on it. If they have a wee at 9 o'clock, they wee in a jug, not a jug from the kitchen, very important instruction. They wee in a jug they bought specially from Wilko's for the purpose, and they measure what they produce and write it down on the chart. Similarly, they ought to do the same at night, which is always met with a lot of whinging, I think you'll find. So the fallback position, if they really won't have it, is wee in the jug at night, don't measure it, but measure the total in the morning and divide it by the number of times you've got up. Why are we bothering with this frequency voiding volume chart, apart from occupational therapy? What's it for? Anybody know? When he comes back and says, "Hey, doc, I've done it," what are you going to do with the information? A couple of things you can do. Firstly, we need to make sure that the patient has actually got prostate problems. They may just be talking about isolated nocturia. And if they're producing more than a third of their urine at night, they may have nocturnal polyuria. So they've got a bit of heart failure, they lie down flat, they've got nocturnal polyuria. I see patients that get sent along with, has this man got BPH? He's getting up 3 times at night and he's passing 700 mils every time. Yep. Now it doesn't matter what operation I do on that man, he's not going to fit more than 700 in his bladder. So he's producing too much urine. So if you've got a patient who's got a bit of heart failure, nocturnal polyuria, how are you going to treat that patient? What are you going to do?
Diuretics.
Some diuretics, yeah. When are you going to give the diuretics?
In the evening time. 1 p.m, 2 p.m.
Mostly when I see them, it's a good idea you've all had in the audience, mostly when I see them, they're still on the 8 o'clock diuretic and they're going to the loo all morning. I try and work out what time they go to bed, because it can be very variable, can't it? Some will go to bed at 9, and then count back from there and put the diuretic in. So in the early evening, they're going to the lavatory, they're dried out like an Arab sandal for night time, so that by the time they go to bed, they're absolutely dry, and they'll get a much better night's sleep. So give them the diuretic in the evening is what I'd recommend, as long as there's not another reason not to. And that is very, very effective. If they've not got terrible heart failure, they've not got swollen ankles, short of breath and all the rest of it, and they're getting up at night to pass urine a lot, or they've got a lot of overactive bladder at night and it's not nocturnal polyuria, how else might you treat those people? Classically, you'll get a chap or a woman who says, oddly enough, I had problems with enuresis, wetting the bed as a child. I was a late bed wetter. I always had my hand up in class, and then I was fine in my 20s and 30s. But in my late 40s, I've gone back to it again. How are we going to help those people? Yeah, so some anticholinergics possibly, some bladder drill, and desmopressin of some sort. So desmo tabs or desmo spray. That's another thing that's worth trying. Clearly need some following up, make sure they're not going to develop heart failure, make sure their sodium doesn't go up the spout. Yeah, make sure their blood pressure's fine, but that's a good strategy for those patients, and there will be quite a few. So let's go back to imagining that this patient's just had his IPSS done, and it's moderate. Do we need to do a rectal examination? Sure, why can't we just do a PSA? It's so much tidier. Yeah. You do really need to do a rectal examination. So I know that most of you will probably be happy with the rectal examination. Here's a bit of joining in, all right? So I want everybody in the room, everybody, and I mean everybody, to take their non-dominant hand and stick it in the air. Non-dominant hand, yeah? Now take your thumb and forefinger and squeeze, and now take your examining finger. And I want you to examine your prostate, all right? Which is your thenar eminence. Give it a good feel. What does it feel? You're not doing. I know you're a manager, but you've got to do it too. So feel your prostate. What you're spotting there, it's got a bit of give to it, but relatively firm. You can move the rectal mucosa over the top. All of that is good. It's got a sort of sulcus when you disappear into your hand. What we're asking you to find when you do this is two things. Have they got such a gigantic prostate that you can't get above it? All right, then you can write large prostate. Have they got two Ferrero Rochers hidden up their backside? In which case you can write prostate cancer and send them up to the hospital. When you see us urologists, you ever seen a letter from one of my colleagues or me saying, many thanks for sending up this lovely gentleman who has a 42.3 cc prostate? Yeah? How good do you think we are at working it out? I mean, I know we've got golden forefingers. In all the studies where they take a patient and we say 45 cc, send them off for a transrectal ultrasound, and it comes back, we are absolutely rubbish at working out how big the gland is, because a major determinant is how full is the poor old patient's bladder when you do the examination. The bigger the bladder is, the more it pushes it down. But if you can't get to the top of the prostate, it's a big one. All right? So that's one thing. You need to decide, don't you, how you're going to work out which tablet to give. So, how do you work out whether you're going to give the alpha blocker or whether you're going to give the 5-alpha reductase inhibitor? What's your thought process? Is it the alpha blocker works by tea time, the patient will be cheerful and will think I'm quite a good GP, the other one takes 6 months and I'll stop bothering to take it halfway through? Or have you got a different way of looking at it? PSA is helpful, yeah? Can you remember why?
The size of the...
It's the size, yeah. So, theoretically, we should base our treatment choice on the size of the prostate gland. Now, I've just said that we're rubbish, haven't I, working it out. So what we use as a surrogate is the PSA. So if the PSA is greater than 1.5, and it's not abnormal, it's not frightening, then what are you going to give them? A 5-alpha reductase inhibitor. They've got a larger gland. 1.5, you've probably got a 40 cc gland. You're going to do well from a prostate shrinking tablet. If it's less than 1.5, 1.4 or less, they're going to do better on an alpha blocker. They've probably got one of these high bladder necks, extra muscle, not so much glandular tissue, more of the smooth muscle element of the prostate. If they've got bad symptoms and you think, there is no way on God's earth I'm going to get this patient to take this tablet that's going to do nothing for 6 months, you know, they're in trouble. So they've got severe score on their IPSS, give them both temporarily. And at 6 months, stop the alpha blocker, leave them on the 5-alpha reductase inhibitor. So what are the side effects of the 5-alpha reductase inhibitors? Yeah, do you see much of that? Yeah, I've seen it from time to time. Should be about 1 in 20. Any other problems?
Hot flushes.
Yeah, have you seen that? Have you? I've not seen that particularly commonly. The other thing I've seen is lack of libido. Again, about 1 in 20. And then there's one more side effect they never complain about. Hair regrowth. You can see I'm not on it, but there we are. Maybe it's not too late. So that's the other one. No one ever moans about hair regrowth. There we are. Well, not the men anyway. So that's the way to choose your tablets.
May I ask?
Yeah.
Timing of the digital rectal examination and the PSA, does it make a difference?
Good question, yeah. I mean, that comes up later in the talk, but we'll do it now. So what do you think? Let's have a vote. Let's have a vote. It's nearly the election in Scotland. So hands up if you think that doing a rectal examination will increase the PSA. Okay. Only if you do it thoroughly enough to be struck off. I think you're probably fine. So just a nice steady prostate examination is fine. I wouldn't worry. If you do a prostate massage, it's a different matter. Don't laugh. We sometimes have to do that in urology. It's not all fun in my department. So no, I wouldn't worry about that. What other things do put PSA up though? Because it's an important question, isn't it? UTIs, yeah. So, yeah, if you go mountain biking. Yeah, mountain biking will probably do it. Yeah. Any others? Instrumentation, catheterisation. Clearly, you'd remember that if you'd done that. What about intercourse? Yeah, so intercourse. How long should they leave it off for, to use a technical term? 48 hours would be reasonable. I agree. Yeah. So 48 hours.
Wait, being silly. That's heterosexual intercourse.
Makes it, yes, yeah. Ejaculation is the thing. Yeah, and I mean it is increased as well in sex with men having sex with men, but again, 48 hours should be fine. And then if they've got mixed symptoms, what are you going to do because quite often they're a bit irritating and they haven't just got poor flow and a bit of nocturia, they've also got some urgency, maybe some urgent incontinence. How are you going to manage that? Is it safe to give them anticholinergics?
Lifestyle measures.
You can try some lifestyle measures. Definitely that's the right thing to do. I mean, I still see people that wake up at night to drink half a litre of Coca-Cola. That's bad. So lifestyle measures are important. No, Derby man and woman doesn't seem to appreciate there's the same amount of caffeine in tea as there is in coffee. Might be worth reminding them. And if the lifestyle measures aren't enough, it's safe to give anticholinergics. How might you give them? I'd say it was fine, so long as you've treated their outflow obstruction first, you've examined them and tried to make sure they haven't got retention, and they haven't got symptoms like, I've got poor bladder emptying, I find it difficult to start. So if they've got poor flow, nocturia, but not a lot of the way of hesitancy, you're probably safer than if they've got some of those more resistant sounding symptoms. But you should be fine. Start gently, is what I'd suggest. When to give up? I think these people do need review. It's tempting to put them on a tablet and send them out into the long grass. But I think the number of patients that I see have got moderate or severe symptoms who are on tablets for years. They have the operation and afterwards they say, "Do you know, I wish I'd had this years ago." Because there's still no doubt that a TURP will give them much better symptomatic relief than even combination tablets. So it's worth remembering that. Obviously, if they've got chronic retention, I'll come to you. Worsening U's, repeated UTIs, suspicious PSA, any of those things, send them up for further looking at.
Do they need bladder scans at any point in the way?
At the moment, according to the NICE guidance, no, they don't. No, they don't. And I think the reason is because not everywhere has got access to a bladder scanner. So in the 2010 guidance, they didn't want people to rush out and buy bladder scanners. The other slight difficulty is that even at the hospital, we can't agree what it means. So you've got the Williams identical twins, okay, Hugh and Simon. You've got Simon saying, "I don't care what their bladder scan result is," and you've got Hugh saying, "If it's more than a tablespoon, I need to follow them up really closely." So I think we as urologists, we're not sure. We haven't got a number we could tell you that if the bladder scan is X, you should be concerned. I don't think we'd be able to agree on that. If you think they've got chronic retention and you're not sure, have you got direct access to ultrasound, abdomen and pelvis? Probably the thing to do, I would say. If you've got easy access to a bladder scanner in the practice or the district nurse has, I think it would be a reasonable thing if you're confident you know what to do with the result.
So the abdominal ultrasound scan, though, you're saying is a sensible thing at some point?
Only if you're worried and you think that they're really not emptying and they're struggling. And the reason I think it's more interesting is if I see a patient who's got a lot on a post-mix scan just with the ordinary ultrasound, I'd then send them off for a proper ultrasound to make sure they haven't got hydronephrosis. So I'm not too bothered if they've got a bit of retention, but I am bothered clearly if they're developing hydronephrosis, because renal failure will be next.
After what size prostate do you recommend for surgical intervention?
We don't really do it on size, to be honest. So if they've got severe symptoms and they've failed medical management, or they don't want medical management. So I think in terms of consenting people, it is reasonable to have that discussion. Though most men, when you say, we could give you some tablets, or we could stick a large piece of stainless steel down your penis, the choice is yours. You know, most people choose the tablets for very obvious reasons. So it's mostly failure of medical treatment.
If you ask for an ultrasound scan of prostate, they said we don't do it.
Yeah, I wouldn't worry. I wouldn't. I think you're getting quite technical there. If you're thinking about prostate size, the only reason I'd be looking for a size of a prostate is if I examined the patient and I thought they were medically a bit unfit and a TURP might kill them, and therefore I need to know how big the gland is to get a feel for the size of the op. Or alternatively, if I've got a PSA that's abnormal and I want to know what the predicted PSA is. So in other words, say the PSA is 6 because they've got a really large gland and the predicted is 7, we can be relaxed, the patient and I, and just keep it under review. So I don't think it would help in primary care. I think just do your PSA, and if the PSA is between 1.5 and whatever the patient's age-related maxima is, they've got a large gland, treat them with a 5-alpha reductase inhibitor, is what I'd suggest.
The PSA doesn't fall after PSA, after 5 reductase.
Yeah.
So that's something to worry about.
We used to say you had to double the PSA to work out whether it was normal. It will normally fall. If it doesn't fall and it stays flat, we're not too concerned about that. But if it starts to rise and they're on a 5-alpha reductase inhibitor, that is more concerning. To tell us about that.
So should we be monitoring our patients on that?
There's not guidance on that. I think it's probably wise though. I think it's probably wise.
Is there a safe period for reductase apart from those signs?
Safe.
Are patients safe to stay on?
Yes, they are, and in fact the results at the moment, the results are that as they get out towards 5 years, every year they get an increased benefit from being on them. And eventually when they get to 5 years it reaches a plateau, and it's not far off TURP, it's nearly as good. I think in the long term, I don't know what the answer will be with them. When we looked at studies, there was a thing called the reduce trial, and they gave loads of people 5-alpha reductase inhibitors to see if it would reduce the risk of prostate cancer. Follow them up for quite a while. What do you think the outcome was? Overall there was a reduced risk of prostate cancer, but there was an increased risk of poorly differentiated prostate cancer. So within urology we had quite a lot of argument about it, and we think that probably what it is if you shrink away the rest of the gland, you make the small bit of growing cancer more obvious. We found it more early. We don't think it's got a direct effect on causing cancers, but clearly it's something which is under review. But that's such an important thing that if it came to light in the future that the tablets did cause prostate cancer, bet your bottom dollar they'd be removed overnight. So I don't think you need to worry overtly as GPs, and that's why there's no guidance on regular monitoring. Is that all right for that? Yeah.
Would you not suggest long-term alpha blocker for anybody then?
Say that again.
Long-term alpha blocker for anybody? No.
Yes, yeah. So if your PSA is 1.4 or less, a little tiny prostate gland, just a bit tight, long-term alpha blocker's fine. But you should just get them back and make sure their IPSS is improved and they're happy. And the most important bit on the IPSS sheet is the question at the bottom, which is, I don't know if you've seen it, it's the bother score. It's, are you bothered? You know, it's quite a modern sort of thing. So on that, they can say how happy would you be if you spent the rest of your life like this? So if they've got moderate symptoms and they're not the slightest bit bothered, we're all happy, aren't we? Yeah. So I think that's quite an important thing to look at.